Bismillahirrahmanirrahim. My name is Dr. Ziaul Haq and I am Assistant Professor of Pulmonology at Gaju Khan Medical College, Sawabi. Today, our topic of discussion is asthma and COPD, chronic obstructive pulmonary diseases. These two are the main types of obstructive airway diseases. So that's why these are important and common diseases. Learning objectives of my presentations are to define asthma and COPD, understand pathogenesis of each disease and the common causes, risk factors associated with asthma and COPD, discuss the clinical features of asthma and COPD, discuss the management of an acute exacerbation of asthma and COPD, understand the long-term management option for asthma and COPD, and answer the questions at the end. Answering of questions are important because at the end during exam you have to answer the question. We'll discuss the definition of asthma. Asthma is a heterogeneous chronic inflammatory disease of the lungs characterized by cough, shortness of breath, and wheezes that is reversible and has diurnal variability. In this definition, there are three parts, rather four parts. One is heterogeneous chronic inflammatory disease. It means that this is a chronic inflammation in asthma, and there is heterogeneity because if twins suffers from asthma, then the sign symptom, the progress, the control, response to the treatment will be different among the twins. That's why this is called heterogeneous. And there will be symptoms of cough, shortness of breath, and wheezes. And this is reversible. When you give bronchodilation, there will be reversibility. Diurnal variability means that there will be difference between the lung function, peak flow during morning and evening time. So this is diurnal variability. The etiology of asthma is unknown, but some factors are present which play an important role, which is genetic factors. That's why, due to genetic factors, asthma run in the family. So, if a patient with asthma comes to you, you should take history of asthma in the family, whether this is present or not present. Environmental factors play part in asthma exacerbation and as well as control of the asthma in response to the treatment. These are pollens, dust, mold, tobacco, smoke, and occupational exposure. Some gases and chemicals can lead to asthma. One term is occupational asthma, like people working in fabric industry they can suffer of asthma. So that is called occupational asthma. And pathogenesis of asthma, when antigen enters the body, this is the antigen, and it combines with the antigen presenting cells. This antigen presenting cell present this antigen to the type 2 helper T cells, which leads to the activation of the release of some mediators, which are IL-4 and IL-13. These mediators activate B cells, which leads to the production of IgE. Multiple IgE are produced. These IgE combines with the antigen. Antigen antibody complexes are formed. Then these complexes leads to the mast cell activation combined with the mast cells, which releases further mediators and leads to the inflammatory reactions. Here in this image, on left side, this is the normal airway. On right side, this is the airway in asthma person. Here you can see the lining of the airway wall is smooth on left side in normal airway. This is smooth, while here this is irregular. So there will be irregularity in the lining of the airways. And here is mucus. Mucus is present. The other thing, this is the swelling of the airway. The other thing is that the muscle, smooth muscle present in the airway or constricted. That is called spasm. So these four things are present. Three things. One is spasm of tightening of the smooth muscles present in the airway, the swelling of the airway, and mucus production. Now we will discuss types of asthma. We have two types of asthma mainly. One is extrinsic allergic asthma. The other type is intrinsic non-allergic asthma. Extrinsic allergic asthma is immune mediated, immune dependent, and that starts in childhood. There will be eosinophilia in blood and sputum, while in non-allergic asthma, there will be abnormal autonomic regulation of airways. And this type of asthma will start in adulthood. And there may not be blood eosinophilia, but sputum eosinophilia will be present. So these are the two types. One is intrinsic and the other is extrinsic asthma. How the patient will present to you. Patient symptoms will be wheeze, cough, difficulty in breathing, chest tightness, and diurnal variation. These are the symptom of asthma. And in between the attacks, the symptom will not be present. Patient will be free of symptom. So This is episodic. Symptoms of asthma are episodic, sometime more, sometime less, sometime absent. In signs, the sign there will not be any signs between the attacks. If the patient has no symptom, so there will not be any signs. When the patient is symptomatic, so there will be prolonged expiration and there would be expiratory wheezes during auscultation of the chest. And if a patient is in acute exacerbation of asthma, so there will be respiratory distress. These are the triggering factors of asthma, which are domestic dust mites, air pollution, tobacco smoke, occupational irritants, animal with fur, pollen, respiratory viral infections, chemical irritants, strong emotional expressions like grief, like excessive laughing can exacerbate asthma. And drugs like aspirin and beta blocker can lead to acute exacerbation of bronchial asthma. Now we will discuss the stages of asthma. One is mild intermittent asthma. In this type of asthma, symptom will be less than weekly with normal or near normal lung function between episodes. Means that patient will be normal between episodes, no lung function decline, and the symptom will be uh, less than once per week, meaning just one time symptom होंगे patient को और week उससे ज़्यादा नहीं होंगे. अगर उससे ज़्यादा symptom होंगे patient को, so that is mild persistent asthma. One is intermittent, the other mild is persistent. So symptom will be more than weekly, but less than daily with normal or near normal lung function between episodes. The other type is moderate persistent asthma, in which there will be daily symptoms with mild to moderate airflow limitation on lung function test. In severe persistent asthma, there will be daily symptoms that interfere with normal activities, frequent nocturnal waking, and moderate to severe airflow limitation on lung function test will be present. In differential diagnosis, you should exclude these differential. One is anaphylaxis. There will be a short history of any drug or bite by something. So anaphylaxis ruling out is important. Alpha 1 antitrypsin disease is another differential of asthma, which can be ruled out by lung function test. In asthma, there will be reversibility, but in alpha 1 antitrypsin disease, there will not be any reversibility. So this is irreversible disease. Pulmonary embolism, anemia, you should ask the risk factor for pulmonary embolism and can do CT pulmonary angiography if you are suspecting pulmonary embolism, and anemia by performing hemoglobin complete blood count test. So pneumonia can be differentiated by doing chest X-ray, bronchiectasis, and bronchiectasis there will be copious sputum for last so many months and years. And tension pneumothorax, there will be reduced air entry on one side with hyperresonant percussion note. And in autoimmune disease, there will be systemic features like joint pain, swelling, early morning tenderness. And metabolic diseases like renal failure, decay, liver failure. Here, you lactic acidosis by doing biochemistry and ABGs, you can differentiate this from asthma. Sometimes you cannot differentiate asthma and COPD from each other. So there is a term which is called asthma COPD overlap, and lung carcinoma and lung fibrosis are another differentials of asthma. And investigation, one can do peak flow metry to know the diurnal variability. Sputum test can be done, which may show sputum eosinophilia and asthma. Routine urine examination is not required. Sometime one can do urine examination to rule out differential diagnosis like Church-Strauss syndrome and other connective tissue diseases, Wegener granulomatosis. In blood test, HB for eosinophilia, full blood count for eosinophilia or hemoglobin is recommended. In ECG, there will be sinus tachycardia. Chest X-ray will be normal in asthma, or sometime if chronic persistent asthma, so may show hyperinflation. And pulmonary function test is done to know the severity of asthma and also to confirm the diagnosis of asthma. Sometime CT and HRCT test done, but not required routinely. Diagnosis is made on high probability, intermediate probability, and low probability. This is an image which shows if there is high probability and diagnosis of asthma is likely, then lung function is not required. But when there is intermediate probability, so here you will do lung function test. If this ratio is less than 0.70%, then this is asthma and trial of asthma treatment should be given. While if more than 0.7%, so this is not obstructive airway disease, other tests should be done, and also in low probability, other tests should be done to rule out other diagnosis. One is acute exacerbation of asthma, and the other is chronic asthma treatment. So now we will discuss the acute exacerbation, which is defined as acute or subacute episode of progressive worsening of asthma symptoms leading to marked decrease in lung functions. Now we will discuss the classification of acute exacerbation, which is moderate exacerbation. In moderate, there will be increasing symptom. The peak expiratory flow rate will be between 50 and 75% of predicted, and there will not be any feature of acute severe asthma. While in acute severe asthma exacerbation, the peak flow, any one of these present, so this is acute severe. The peak expiratory flow rate will be between 33 to 50% of predicted. The respiratory rate will be more than 25 per minute, heart rate more than 110 per minute, inability to complete sentences in one breath. So you should know that what is moderate exacerbation of asthma, acute, severe, life-threatening, and near fatal asthma. And life-threatening पेशेंट को एक्यूट सिवियर के सिम्टम होंगे और उसके साथ साथ peak expiratory flow will be less than 33% of predicted, and oxygen saturation will be less than 92%, partial pressure of oxygen less than 8 kilopascal or 60 millimeter. The normal PaCO2, silent chest, cyanosis, poor respiratory effort, arrhythmia, exhaustion, altered conscious level. So these are the signs of life-threatening exacerbation of asthma. In near fatal, there will be raised partial pressure of carbon dioxide, means more than 45 or more than 6 kilopascal, or patient requiring mechanical ventilation with raised inflation pressure. Now we'll discuss the management of acute exacerbation. Here a mnemonic use, which is SOSA. First, S stands for salbutamol, O for oxygen, other is for steroid, and the A for antibiotic, which is plus minus. So in each emergency, you should maintain airway, you should clear the airway, you should check the breathing and the breathing pattern and the circulation, the pulse of the patient. If not, patient is comatose, airway is not protected, airway should be placed, Godel airway should be placed, and oxygen should be given to the patient. In nebulization, salbutamol nebulization, usually we give beta agonist, salbutamol and apratropium nebulization, and steroids is also important. And if infection is suspected, so antibiotics given. If patient doesn't improve with these treatment, then IV magnesium sulfate or aminophylline given to relieve patient symptom. In long-term management of asthma, our aim is to, there should not be symptoms during the daytime and no waking at night due to symptom, and there should not be any exacerbation, no need for rescue medication, no exercise limitation, and there should be normal lung function. These are our aim in long-term management of asthma. Yearly asthma review should be done, smoking status checked, and patient should be concerned regarding quitting smoking. Triggers and avoidance of triggers history is important. Inhaler technique should be checked, and stepwise approach is recommended in this long-term management. These are stepwise, step up and step down approach in asthma, chronic long-term management. Step 1 to 5, and step 1 only short acting beta agonist used, while in step 2, continuous low-dose inhaled corticosteroid are given and short-acting beta agonists are given on need basis. While in step 3, long-acting beta agonists like formoterol and salmeterol are used. Along with these, inhaled corticosteroids are given with the short-acting beta agonist on need basis. In step 4, other drugs are added. In addition, the inhaled corticosteroid dose are increased to high doses. In step 5, oral corticosteroids are added like prednisolone for short duration, 5 to 10 days. So this is the long-term management of asthma, which is step up and step down. Now we will discuss the chronic obstructive pulmonary disease, which is defined as this is a collective term for an inflammatory lung disease in which airway obstruction is progressive and only partially reversible by bronchodilators. So this is almost irreversible or partially reversible. Mainly, COPD has two types. One is chronic bronchitis and the other is emphysema. Chronic bronchitis is defined as the persistent cough with sputum production for 3 months per year for 2 years consecutively. Sorry. And emphysema is an anatomical definition, which is permanent enlargement of air spaces distal to the terminal bronchiole due to alveolar septal destruction. This is the pathophysiology of COPD, and here you can see that genetic factors are involved, like in alpha 1 antitrypsin deficiency. There will be alpha 1 antitrypsin deficiency in this patient. Other is smoking, biomass burning, and occupational exposure, dust exposure. These all leads to the inflammation. When biomass, smoking, dust enters the lung, inflammation created, and then there will be increased neutrophil elastasis and MMP matrix metalloproteinases leads to the destruction of alveolar wall and capillaries. So the symptom of asthma and COPD will be the same, but with some differences. Like asthma will be episodic, COPD will be progressive, slowly progressive. Both can have wheeze, chronic cough, shortness of breath, regular sputum production, frequent winter bronchitis, and asthma patient will be younger, while the COPD patient will be more than 40 year of age, and there will be history of smoking or biomass fuel exposure in COPD. In sign, these are the two terms used for COPD patient, severe COPD. One is pink puffer, other is blue blotters, and there will be respiratory distress, hyperexpansion of the lungs, barrel chest shape, and percussion note will be hyperresonant on both sides if the hyperexpansion are more, and there will be prolonged expiration with expiratory wheezes. The differential diagnosis are almost the same as of asthma. So you should exclude these differentials. Investigation are almost the same, but here you can see the ABGs, arterial blood gases, are important in COPD management because in asthma there will be type 1 respiratory failure, but in COPD, in end stage, you can see in end stage COPD, there will be type 2 respiratory failure. That's why the ABGs are important. This is a chest X-ray of COPD patient. Here you can see this is hyperinflation. One sign of COPD is hyperinflation. We label hyperinflation when there will be the more than 6 ribs, interior ribs, and midclavicular line. One is this interior rib, this is second, this is third, this is fourth, this is fifth, this is sixth, and this is seven. So this is the midclavicular line, and here you can see 6 ribs is present here. 6 interior ribs. These are posterior ribs. You should know the interior and posterior ribs. So more than 6 ribs, 6 interior ribs in midclavicular line. So this is hyperinflation of chest X-ray. Another sign is the uh, bilateral hilar prominence. These are the hilar prominence. Hilums, the bronchovascular marking are prominent in both hila. The other sign is tubular heart. Here you can see in normal patient, there will be 1/3 of the heart, 1/3 of the heart will be present on right side of this vertebral column and 2/3 on left side. Here you can see there is no heart on the right side. So this is like a tubular heart. The other sign is there is the flattening of the diaphragm. This is rather flat. Diaphragm is flat. Curve is not present. In normal patient, there will be curved diaphragm. Curved diaphragm. So these are signs of COPD on chest X-ray. This is a spirometry image. This is called, this is obstructive pattern because asthma and COPD has obstructive airway disease. And this term is called dog leg appearance in emphysema. Okay, treatment of acute exacerbation of asthma and COPD are same, but with the addition of two things. One is in asthma, we give labral oxygen. Oxygen saturation target will be more than 92%. 92 to 95% is our target in asthma, and more than 95% in pregnant patient with asthma. While in COPD patient, our target is 88 to 92% target oxygen saturation. The other thing is non-invasive ventilation, which is by PAP. If patient if patient is in type 2 respiratory failure and has partial pressure of carbon dioxide more than 45, then we give trial of non-invasive ventilation in the form of BiPAP with an excellent result. In long-term management of COPD, we advise the patient to quit smoking. Smoking cessation is important. Vaccination against influenza and pneumococcal. These two vaccinations are recommended, and pulmonary rehabilitation. These three steps are the long-term management, non-pharmacological treatment. While in pharmacological treatment, these are the drugs in the form of inhaled therapy. If patient has less symptom, okay, initially if patient has intermittent symptom, so then short-acting beta agonists or short-acting muscarinic agonists are used, then lung function done. If EV1 is more than 50% of predicted, then LABA or LAMA are added, long-acting beta agonist or long-acting muscarinic agonist. LABA are formoterol and salmeterol. In LAMA, we have the option of tiotropium. If the lung functions are less than 50%, then we add inhaled corticosteroid with LABA and LAMA. But when patient doesn't improve with these treatment, then LABA, LAMA, and inhaled corticosteroids are added to the patient. And long-term management of COPD, we have mucolytics, which are N-acetylcysteine, erdosine. We have oral bronchodilators like theophylline. This has a narrow therapeutic window, and one should give this drug carefully. And oxygen, long-term oxygen therapy, which is called LTOT, and short burst of oxygen therapy, SBOT, and home NIV, non-invasive ventilation. And we have a surgical option in the form of bolectomy, lung volume reduction surgery, and lung transplantation. So these are the long-term management of COPD. This is a large bola. On right side, this is a bola, air containing sac, which is called bola. Here, the removal of this bulla will help this lung to expand and will take part in respiration. This is oxygen concentrator. Uh, this is used for patient requiring long-term oxygen therapy, at least 16 hours per 24 hours. And this is a machine which is called non-invasive ventilator, NIPPV, non-invasive positive pressure ventilator or ventilation. This is a face mask. All of you may be aware of this because in COVID we have used this machine in almost every hospital. This was an article published which shows that inhaler technique error are much common, 83% in patient with obstructive airway disease. So whenever patient comes to you, you should check the inhaler technique of the patient. This is a history of a patient. You should read this scenario and then answer the following question. This is another scenario. Read this scenario and answer this question. This is your homework. If you answer this question, it means that you will not have any difficulty during exam. Thank you.